So I would imagine that if I was 12 and my parents thought, gene therapy was the way to go for Wunmi, would the conversation about fertility preservation be brought up? And what does that look like for pediatric patients? Hey, Sickle family. I'm Wunmi Bakare.
I'm Christelle Salomon.
With a special guest appearance from Dima Hendricks.
And we would like to welcome you to the Through the Genes podcast,
where we talk about living,
healing,
recovering,
and exploring transformative therapies for sickle cell disease.
We will also talk about our individual journeys and the bond that we have built as sickle cell sisters. Earlier on in the episode, we talked to Dr. Mark Porteous, who delved into all things what happens to the body as it goes through gene therapy. Dr. Krieger is both an expert in cell and gene therapy, and so we felt it was best to also ask her feedback about the process for stem cell transplantation as well.
So wonderful to be here with you guys today. Thank you for having me.
Christelle.
Welcome, Dr. Krieger. I'm so excited to have you here. For those of you who haven't met Dr. Elizabeth Krieger yet, she is a pediatric hematologist-oncologist at the Virginia Commonwealth University, which you may have heard of as VCU. She's an expert in bone marrow transplant and cellular therapies for patients with a wide range of rare conditions like metabolic disorders, immunodeficiencies, as well as hemoglobinopathies like sickle cell disease. I actually met Dr. Krieger maybe a month or two ago, and from the very beginning, there were two things that were super apparent about her. And one is that she is an expert through and through. She knows the details that I feel like sometimes providers don't need to know, but she knows them and she knows how to explain them to you, which I appreciate. And also you can tell there's a level of passion and care that she has for her patients. And when I talk to Dr. Krieger, I feel safe and cared for, and I'm not even her patient. So I noticed those things right off the bat, and I'm just so honored to have you on the call today, sharing your expertise and what you know. And I know the audience is going to benefit from it so much. So without further ado, welcome to our podcast, Dr. Krieger.
Oh, thank you so much. Those are very kind words. I really enjoy getting to work with you guys and with all of my sickle family that I get to take care of every day here.
She called us sickle family.
I know. First provider to do that, and I love it.
Oh, good.
To acknowledge that
wonderful.
We are small but a mighty family. All right. So starting things off, Christelle and I are both transformative therapy recipients. I had my transplant exactly 5 years, and I want to say a little over 6 months ago. And Christelle is 3 years post. So she has a more fresh recollection of the experience that I do. But one of the things that I wanted to talk us through is kind of the pre-treatment and the conditioning stage, because for many people in learning more about cell and gene therapy, the frequent question is, why is hydroxyurea stopped? And why is red cell exchange used to treat the patient to help them get to a safe enough state where they would be perfect candidates for a transplantation? So could you kind of talk us through what happens to the bone marrow at the different stages of the transformative therapy process, specifically the preconditioning stage?
Yeah. I like to talk about this as kind of like the pre-work, the preconditioning with my patients. It's a little bit different than transplant. So people who are more familiar with transplant know that there's a lot of post-work where you're in the office very frequently after transplant, looking at immunosuppression and those different things. With gene therapy, there's a lot more upfront pre-work, which starts with those exchange transfusions like you're talking about, or you were mentioning. So your bone marrow, when you have sickle cell, is a very revved up system. It has a very high turnover of the stem cells and the different kinds of other cells that live in your bone marrow, because your red cells don't live as long in your body. So it needs to keep up with making more of them. The red cells that are prone to sickling also can increase the inflammation in the bone marrow, which stresses that system. And so To help decrease that stress and that turnover, we use exchange transfusions, or if you're really tiny, like little kids, we can sometimes use simple transfusions. But the exchange transfusions bring down the percent of sickled hemoglobin that patients have in the body. Our goal in general is less than 30%. And we replace that sickled hemoglobin with donor hemoglobin. This will increase those. It also increases your hemoglobin parameters. So meaning that, most or a lot of patients with sickle cell have a lower baseline hemoglobin. After these exchange transfusions, we tend to keep the hemoglobin higher. And what that can also do is decrease that bone marrow's drive to make new cells. When your body senses it has enough cells and enough what we say oxygen carrying capacity, which just is a fancy way of saying you have enough red cells to really adequately get oxygen to the other parts of the body, it'll also turn down or decrease that turnover of those stem cells. With that being the goal, decreasing the turnover and decreasing the inflammation, we hope that the bone marrow can concentrate more on making stem cells, which are what we want to collect in this instance. So instead of using someone else's stem cells, like we do for transplant, we want to use the patient's own stem cells. We then think about stopping hydroxyurea. Now, protocols can be different, institutions can be different, but in general, at least 4 weeks before the first collection, because hydroxyurea, which is a super important part of supportive care for our sickle cell, it increases the fetal hemoglobin in the body. And fetal hemoglobin is great. We're going to talk more about fetal hemoglobin, I bet, later. It can decrease complications, it can decrease pain, but the hydroxyurea increases that fetal hemoglobin by causing a little bit of stress to the environment, which will decrease the amount of stem cells that are produced. And so we stop the hydroxyurea so that the bone marrow will hopefully be able to produce more stem cells.
It sounds like the entire essence of that red cell exchange at hydroxyurea is to make sure that you're taking up all of the possible stress that could be impacting the bone marrow, because you need the bone marrow to be in like tip-top shape. I'm imagining this in my very animated mind as like a protective covering over the bone marrow so that it focuses on the work it's supposed to do. I wanted to ask, what is the hemoglobin level that a patient needs to maintain for them to be able to get their stem cells harvested? Because you mentioned that there's a certain hemoglobin level that you make sure it doesn't drop below. What is that number?
Every protocol and every institution may be different, but in ideal situations, we try and keep it above 9 or 10, depending.
Okay.
Thanks for giving us, it's like there are so many, we're in a game. Like this is a video game and there are so many different moving parts that we need to be keeping track of player A and player B and player C, because they all play an important role in making sure that we're setting up the patient for the most successful transplant or gene therapy process as possible. And so I'm curious, as we talk about preparing the body for receiving this transplant, can you tell us a little bit more about the chemotherapy process? And this is specifically, patients hear about chemotherapy, they hear about conditioning, and there are lots of concerns because we know that there are side effects. And so can you just tell us, what exactly does chemotherapy do to the body, and why is it necessary to do before embarking on transplant and gene therapy?
Yeah, absolutely. This is one of the most common questions I get from my patients. Sometimes patients come in knowing that they would need to receive chemotherapy, and sometimes that's a surprise. And hearing the word chemotherapy for the first time, when you're sitting in front of your provider, as much as I don't want it to be, I think it can be a really intimidating part of the, first conversation that we have. But our bone marrow, where we make our stem cells, which produce our red cells, which are what we want to replace in the instance of sickle cell, our white cells, which fight infection, and our platelets, which help clot our blood, all come from stem cells in our bone marrow. This is like a bucket of a system, right? We have these stem cells that keep renewing and keep filling that bucket. So at all times, it stays full. If I was to take someone's gene modified cells and give them back to them without any sort of chemotherapy beforehand, that bucket is full and those cells wouldn't have anywhere to go and to grow. So they kind of just, I think about it as a bucket, like they just flow out of the sides and it wouldn't be effective. And so we need to empty out that bone marrow bucket to allow those gene modified cells to come back in and fill it back up. Right now, the only way that we have to do that is with chemotherapy. We use traditional chemotherapy with gene therapy because it kills the fast dividing cells in the body, which includes your stem cells that live in your bone marrow. It also hits other fast dividing cells in the body. So it hits the, taste buds in the hair cells. So after gene therapy, patients may not experience the taste of foods to be the same. We do see thinning of hair, if not most hair falling out. I have not yet had a patient who's gone through gene therapy who has decided to keep what hair may stay. All of my patients have decided to shave their head. That could change with time. But when it hits those fast dividing cells in the body, it causes side effects.
What are some of the most common side effects outside of change to the taste buds and thinning or loss of hair? What has been some of the common, and this might differ for genders as well, that you have seen with your patients, and how can we best prepare them to be able to manage these complications?
Yeah, that's a really, that's powerful to hear your experience. One of the things that my beginning of my training was primarily with patients who had, leukemia and the other, diseases where they had experienced chemotherapy before coming to transplant. And when I expanded my training to include patients who had metabolic disorders or hemoglobinopathies, the discussions around these side effects of chemo upfront become some of the most important conversations that we have because they don't have a background for this, right? And so we handle them a little bit different, right? Everybody has some side effects from chemotherapy. The common one that people think about and we see in movies is the nausea and vomiting that go along with it. Up front, I ask that my patients be as honest as they can with me and my team while they're going through the process, because the only way we can know how it's going and how we can help fix it with different nausea medications and the like is if they tell us how they're feeling and how the medications are working and how they're not working. We can't take away necessarily all of that feeling, but we can definitely help mitigate it, especially with good communication. One of the other complications that happens for everybody who gets this amount of chemotherapy is pain. There's pain with this therapy kind of from two buckets. So the traditional kind of, we call it mucositis, which is just a fancy way of saying sores in the mouth all the way through the GI tract. You're actually kind of a donut if you think about it that way. You have a hole in your middle all the way down through, and you can get those sores in that area because your cells that are there turn over quickly as well. So they're affected by the chemotherapy. It's particularly important to think about this in the context of patients who have sickle cell, especially those patients who are older, because they have a significant history of having chronic pain. And when you have a history of having chronic pain, your body's essentially tuned up and dialed in to listen and feel any new acute pain that it meets. It's got a name, it's called hyperalgesia, but it just means that the way that people who experience chronic pain experience a new acute pain may be higher. And so, it's really important for the CIT team to help manage the acute pain properly from the mucositis, but there's also pain in the body that goes on during these therapies from sickle cell pain. Think about it, you're sitting in a bed a lot of the time, your energy's decreased, you can't get up and do those different pieces of your routine that help with that. And so we also round at my institution with a sickle cell team to make sure that your pain is managed from both sides in the most appropriate ways. This is always a conversation that's most difficult to have with my young adult males because, I mean, rightfully so, I don't know what it's like to experience sickle cell. I just don't. I don't have any kind of understanding for that. And so it can be hard for them sometimes to hear from me about what this pain journey might be like because I don't have any reference for it other than helping other patients through it. And so the communication between the providers and our patients is really important so that we can hopefully support each other as best we can through. They can support me to help me understand what they're going through and what they've been through, and I can help support them with this new journey. Fertility is another aspect of chemotherapy that we often talk about, or we should always talk about it. And if we're being perfectly honest, I don't think I go through a consult where we don't talk about it. And fertility after gene therapy or transplant in general, and decreasing fertility associated with chemotherapy, in my personal opinion, it is an area that's understudied, especially for our patients with hemoglobinopathies and sickle cell. I can't look at a patient before they go to therapy and say, you will or will not be able to go on and have children unassisted or assisted later in life. I hope that we'll get clearer testing and understanding of that in the future. But for right now, what I do tell my patients is they should always assume that after therapy, they can get pregnant and, use protection if that's not what they're looking to do at that time. We always discuss that while we are manipulating genes in the bone marrow, we are not doing that in their eggs or their sperm cells. So those will always carry the sickle cell gene. And I always encourage them to, at least if they want to, learn about fertility preservation, like egg harvesting and storage or sperm storage, so that later on, if they choose to, they have that option if they need it.
Okay. I'm going to rephrase the question. Sorry.
Yeah, go for it.
Pediatric patients, it's a different journey. They're girls and they're boys. They're not men and they are not women. And so fertility preservation for a child works differently, especially if the child, let's say for the sake of this conversation, is 12. I don't know if sickle cell impacted the age I started my period, but I didn't see my first cycle till I was 13. So I would imagine that if I was 12 and my parents thought, gene therapy was the way to go for Wunmi, would the conversation about fertility preservation be brought up? And what does that look like for pediatric patients?
Yeah, absolutely. We do bring that discussion up with every one of our patients, even patients who haven't started their menses or started to go through puberty. We discuss that with them and their parents. And when you're 10, 11, 12, oftentimes you are just so not interested in that conversation and so not interested in your parents discussing that conversation. But we always talk about it. I've had personally a patient decide not to go on a gene therapy clinical trial. Her mother and father decided not to do it because that was something that they were not willing to potentially affect, was this patient's fertility. For girls who have not started menarche, there is, besides oocyte or egg collection, there is another form of fertility preservation that's ovarian tissue harvesting. This is, great. Back when I was first training and learning, this was still something that was being done on clinical trials. Since then, it is now done as more of a standard of care for our patients who are younger than the age of 12 or not have starting their puberty journey. However, it does require an abdominal surgery. And so some parents decide that that's not for them. Not every institution does it. My institution here does for older patients, but doesn't necessarily for younger patients. And so we suggest families that are interested in it go to one of the other centers in the area to discuss that with their fertility preservation team.
Wow, this was such a helpful conversation. And what's encouraging to me is that you can tell it's a partnership. And I think so many warriors who have gone through transformative therapy in the past have said, like, I don't think I fully know. I didn't know what I was walking into. I wasn't told all of the potential options, good and bad. And for me here, like, hearing this is the standard, that things are brought up early and often, and that people can walk in with not rose-colored glasses, but with eyes wide open, and be able to make informed decisions. And it may mean not getting therapy. It may mean getting therapy and making, having the understanding that this is going to be a really hard journey going through IVF and like running right into transplant or gene therapy, but that a decision was able to be made by the people who are involved. And before we wrap up this conversation about conditioning, I wanted to ask, so when I did my transplant, I got chemo, but then I also got radiation. And I didn't realize some protocols had radiation and some didn't. And so can you explain to us what the difference is between including radiation in a treatment protocol versus not?
Yeah, no, absolutely. In general, we're always looking to try and decrease the amount of radiation that our patients are exposed to. And in general, we're always trying to decrease the amount of chemotherapy that patients are exposed to as well. But it's a balance. We need to make sure that the transplant, we try and make sure that the transplant is going to be as effective as it can be. Um, so right now, just for understanding, none of the gene therapy products that are FDA approved use radiation as a part of their conditioning regimen. And to my understanding, none of the others that are being studied right now do either. But radiation can be an important part of the transplant journey. And so it's definitely good to talk about why we use radiation. Nowadays, radiation is primarily utilized in non-malignant transplants in situations where there's a higher risk of what we call graft failure or graft loss. It's a fancy way of saying that the donor cells that you get may not grow back, or they may grow back and get lost over time with the patient who received the transplant cells growing back on top of those donor cells, which could result in patients with sickle cell then going on to have sickle cell symptoms again, which is exactly what we want to avoid, right? We don't want someone to have gone through the transplant process and then have reemergence of those sickle cell symptoms. So to try and help avoid that graft loss or that non-engraftment, after some very early initial transplant protocols, when we saw those signals, radiation got added back in its small doses to help prevent that. And it's something that we saw in the sickle cell population. We have other populations like aplastic anemia where we did very similar things as well. But that's why radiation got added to those protocols.
Okay. Good to know, because if I'm honest, until you just spoke about it, I didn't know the function of radiation. I just assumed it was part of the conditioning to be safe. But I guess if graft loss is going to happen, we definitely don't want a patient to have gone through that really grueling journey only to end up in a place where the success of their transplant is determined by whether or not they went through the radiation process. I know that for some sickle cell warriors, when they are younger in their teenage years, they can lose their spleen. Does that impact the success rate of gene therapy?
We've had success with gene therapy for patients with or without a spleen, and that's for sickle cell and for beta thalassemia, the other indication for this. When you watch patients go through this therapy, patients who don't have a spleen anecdotally have a shorter time to those platelets growing back because they don't have to refill their spleen with those platelets. And so sometimes they end up discharged a little bit quicker from the hospital.
Wow. My mind just blew. I'm like, wait, so not having a spleen is a flex?
This is wild.
In this instance, it can be.
Whoever knew a bad thing could be a good thing in the end.
Yeah, no, definitely. It's not something we always try and avoid taking out people's spleens because it can have effects on how you respond to vaccines in the future and your risk of blood clots. But when I talk to patients and tell them, oh, you don't have a spleen, maybe your platelets will engraft or come back a little bit sooner. They're just like, haha, finally it's worked for me. So true.
That is wild. Having my spleen was still great, but maybe in some instances it's not so much. But before we move on to the very last segment of our podcast, I wanted to talk about a concept. And there are some patients that are concerned about the idea of changing their genes. Can you explain to us what happens on a genetic level and how the treatment is designed to be a one-time solution? Because that's like the big upside that we hear pharmaceutical companies and research institutions like, this is the option for a one-time treatment. How does this actually work? How is it actually a permanent solution?
Yeah, no, that's a really great question. I do want to point out that right now there are several ways that stem cells are being altered to transform sickle cell disease. And we'll go over kind of the two that are FDA indicated right now. But it's important for patients to remember that the mutation that causes sickle cell is not being corrected with these two products. We're kind of using, I like to explain it as like a back door to produce a new hemoglobin. So patients will still produce sickled hemoglobin, but in a much lower amount, analogous to patients who live with trait. So there are two big buckets for transformative therapy right now. One of them is called gene addition therapy. This works using a virus. Its fancy name is a lentiviral vector. And in this instance, the lentiviral vector is used as kind of like a package to put a new hemoglobin gene, a new hemoglobin beta unit into the cells. And that's the particular subunit that's altered in sickle cell. There's a second, and so what happens is the beta can now work with the alpha and make an adult hemoglobin, which happens to be called hemoglobin A, and go on to produce biconcave disc red cells that don't sickle. That's the one that's just a smidge easier to explain. The currently approved gene correction therapy uses a CRISPR system. It's a targeted gene editing tool. It's kind of like molecular scissors. I actually had a provider who I was teaching this to in my gene therapy, and whenever I talk about it, she goes, which makes me laugh every single time. But in our bodies, we have a gene that controls the production of fetal hemoglobin. I'm sure your providers have talked to you about fetal hemoglobin before as it relates to sickle cell care, particularly around hydroxyurea. Instead of using a medication like hydroxyurea, we can turn off this BC11A gene, which allows the body to produce fetal hemoglobin in an adult. So fetal hemoglobin doesn't have that beta subunit that's mutated in sickle cell. And so you go on to, once again, produce those biconcave disc red cells, similar to the other therapy, just two different ways of accomplishing a similar end. Like we talked about a little bit before, just important to make sure to hit home, this only targets those stem cells that we've taken from the bone marrow and then put back. And so the other cells in the body, like the sperm and the eggs, are not modified in this instance. Our bone marrow bucket is kind of this self-populating system. And so those stem cells, their job is to keep that bucket full all the time, and they are constantly replenishing. When we take out and replace those stem cells, the thought is that as long as we replace enough of them and they continue to grow and divide, this is our hope of lifelong transformative therapy. One of the things that I talk about with my patients is, I don't have 12-year-olds who are 50 because this therapy hasn't been around that long. And so there is a little bit of that inherent risk in just the fact that we don't have as long of a history of doing this therapy as we do with transplant.
I love these analogies. I think they are so helpful for understanding how this works. The bucket. I love the bucket and the scissors. I have a quick tangential question that I feel like would be appropriate to address, and that is considering how the vector, the viral vector works. How is it that the viral vector is able to make the edits or not? Okay, let me take that back. The viral vector is not editing. How is it that the viral vector is adding this functional beta globin unit, but doesn't actually replicate itself, and I'm not sick with the virus if I were to get this treatment?
Yeah, no, that's a really great question. Um, Besides talking about chemotherapy, one of the biggest eye-opening pieces for my patients when I talk about this therapy with them in the office is when we talk about a lentiviral vector. A lentiviral vector is a pared down HIV virus. So the HIV virus has infrastructure inherent to it to be able to take larger pieces of genetic material and insert them into a cell. And so we've been using lentiviral vector therapy in medicine for a long time to do just that, insert new genes. The most common one that people may have heard about outside of gene therapy for hemoglobinopathies is a therapy called CAR T cell therapy that we use to treat leukemia. In that instance, we're putting a new receptor on a cell to go and kill and target leukemia cells. In this instance, we use this package to put that new hemoglobin gene in. The trick is that all of the pieces of the virus that would cause the disease, HIV, are taken out. They aren't there anymore. And so no one has gotten HIV from a lentiviral vector. But one of the caveats that we also talk about with patients is that it's so similar to an HIV virus that when patients later on go on to potentially need a visa or get a new job or need testing for some reason, if not the proper test is done, they could test positive falsely for HIV. And so we talk about that and how they should suggest to their providers that, hey, I've had gene therapy. We need to be mindful about which way you test me for HIV. To be perfectly honest, I mean, for CAR T cell and gene therapy patients, it could happen in a medical setting like our offices too, where somebody just didn't remember their history.
Okay. So I want to ask our final question before we move into my favorite section of the show, which is, what do you wish more people knew before starting the gene therapy process? And are there any misconceptions that you've heard that you're like, who started this rumor? And it needs to absolutely stop because that's incorrect information.
Yeah, no, those are really great points. One of the things that I often see is that patients who are encouraged to come in by their families may not have a good grasp on what it all is encompassed in this therapy. One of the most important things that we go over is actually how long this therapy takes. It's a big time commitment. Pre-testing to see if you're eligible and ready for the therapy. There's submission and approvals that have to come back from your insurance. There's the red cell pre-exchange portion if you haven't already been on those for your sickle cell journey. There's the manufacturing portion, which runs between 3 and 6 months. And then there's a significant time for the admission to the hospital, which ranges from like 35 to, in some instances on clinical trials, 72 days. So I have a conversation with my patients about what their life goals are right now, what they're trying to accomplish, what they want to accomplish in the long run, and where this like very long process can fit in if they think it's right for them. Their families can say whatever they want, but they're going to be the ones that are in the hospital that long and coming to do all of these things. And so they absolutely have to want it and have to buy in. I've had a patient who came to see me and told me, yeah, I took this year off from college to get this therapy. And I had to let her know that, it was going to be at least 9 to 12 months before she was discharged from the hospital. And so if you can, you might want to start this semester of college and then plan to take off next semester or the semester after that, which can be completely eye-opening for patients because it is talked about in the media, so nonchalantly, if I'm being perfectly honest. It's also really important for patients to know what their support system looks like because they are going to absolutely need that during this therapy. I love it when people come for their first, second, third consult with the people that they recognize they want to be their caregivers because everybody needs to hear about this more than once. I try not to do just one session talking with somebody about it and then kind of moving on. We like to meet, discuss what it looks like, have them go home, talk to their support system, talk to the people who help them make decisions in their lives, and then have them come back again and rediscuss it with us. And if maybe their support person didn't come that time, they come this next time so that they can hear it from the providers and the nurses in clinic and everything like that too. And then the one other thing that I'm trying to learn to talk to my patients about is the potential kind of change in their identity, because that can be really eye-opening for patients after therapy. Living with sickle cell can be all-encompassing from what I understand. And from coming and doing this therapy that's also all-encompassing, when it's over and through, what do you want your identity to look like? What are your goals after that are really important to talk about so patients don't tend to feel like they're swimming in it afterwards.
Whew. Dr. Krieger, thank you. I deeply appreciate the points you made because each and every one of them speaks to me directly. It's the hardest thing I've ever done. I always preface by saying that, but I will never regret the decision. If I had an opportunity to do it all over again, in a heartbeat, I wouldn't even think twice. Just because of the significant change in my quality of life. But I think sometimes what is harmful, and this is publicist Wunmi now, is when the media does stories of, the typical arc of this is a patient that's going through a really difficult time. And then this is them after, and they have kids, and they're married, and they have a fantastic career. And the reality is, in the same way in which these novel therapies are being marketed, it feels very pretentious, like how we feel about like Mattel advertising of selling a Barbie or Legos, right? And then in the fine print, they say, doesn't come with all of these extras. You know what I mean? And the reality is, with gene therapy, it's nuanced, it's novel, not a lot of research. There's not a lot of research information to heavily be able to rely on should the patient encounter any other issues later in the recovery process. And we need to better set realistic expectations for patients. And so I think it's really, really important that we break these misconceptions, but we also prepare both patients and their support systems to be able to work collaboratively with the healthcare team and helping the patient to get to a point where they feel like I'm in control, I'm back in the driver's seat of my life. So I deeply, deeply appreciate you coming on our show. And now we're going to move to my favorite segment, which is rapid fire questions. Dr. Krieger, we have gotten to know you from a provider point of view, but this section of our show is tailored to getting to know Beth, not Dr. Krieger, but Beth. And so with that, I wanted to start us off with, if you were an element on the periodic table, what element would you be and why? And you have only 2 seconds. I forgot to mention the big staple. You can't think. You just got to go. 2, go.
Okay. Well, if I was an element on the periodic table, I might pick like neon. I've got that
Okay.
excitable electron that can make me shine and be really brightly colored. Because I like to be bright and colorful and have fun that way. I don't know if that makes sense.
What makes sense? You know who you. I'm gonna say something. Please take it in the spirit in which is intended. You remind me of happiness in Inside Out, like joy. No, not
Aw,
happiness. Her joy on
I knew
Inside
what you
Out. You
meant,
remind
Joy.
me of huge joy from the animation, the Pixar animation Inside Out. But Christelle,
That's very
sorry.
kind, I think. Yeah, thanks.
You definitely neon suits you super well. On the topic of more joyful things, what is one thing that always makes you smile no matter how hard the day is?
So I'm a big gardener. I like to um, go out in my garden at the end of the day, and my son and I will run around and pick different flowers so that we can give them to our neighbors and to people at work. And so the process of picking them and being with my son and then giving them away just has so many different ways of giving me joy.
Oh, I
That is
love that so
the sweetest
much.
answer in the world. Okay. This is you're gonna like this one. If you could have dinner with any historical figure, living or dead, who would it be?
Ooh, you know, I have been learning a lot about Einstein's wife recently. That's been one of my interests. She was an incredibly pioneering woman for her time, um, and really had she was really the support and I think a lot of the ideas behind Einstein's initial work. And so I would love to get to sit down with her and learn more about how she handled those situations and her strength.
I'm gonna quickly jump in here. Behind every successful man is an even more powerful woman. And so you shedding light on wanting to have a conversation with Einstein's wife, sometimes we forget that statement. And sometimes I'm like, sometimes you level up by the person you choose to partner with. So I'm curious. Now I'm like, oh my God, I'm about to drop into a rabbit hole online and dig more into this woman's story
Yep.
because I'm curious.
I love to read historical fiction that's it's based in events, but and so her and then I couldn't decide between her and Rosalind Franklin, the woman who was actually the one we think who put together the DNA structure. Um,
Yes.
and then it kind of got, um, yeah, I love learning
Snatched,
about
stolen.
strong female figures, particularly from science and history.
Well, I want to be invited to that dinner as well, if that is allowable.
Sounds great.
On to our second to last question. What is one simple health tip that everyone should know, but most people ignore?
Get up and move as much as you can. It's good for your body and it's really good for your mind. I know that another way that I decompress is by going on a walk and just giving myself some time to breathe and be in nature.
I don't know if all of the doctors are texting themselves before they come on our show, but if I've been struggling with God and I've been like, I'm lazy today. I'll work out tomorrow. I promise I will. And you are the umpteenth person who's like, get up and Wunmi is like, really? Do I need to? And it's interesting because I was telling my boyfriend this that like I think the reason why I'm such a homebody is because I was sick a lot my whole life. So if I don't have vitamin D or take a walk, I can exist. My mom always was like, "You'd be great for Big Brother." I can exist in a house and not leave that house for like 90 days, and I would be okay. People would be like, "Oh my God, I'm losing my stuff," and I would be like, "My marbles are complete. I'm fine. This is fantastic." So it's interesting that you share that. Okay, final question. If you could time travel, would you go to the past or would you go to the future?
Oh, that's a really good question. It's going to sound really weird, but I have a family that's really into dinosaurs.
Okay.
Like they it's a conversation all the time and we talk all about these dinosaurs and we don't really know what it was like back then. I think I'd like to go back and really see what dinosaurs looked like and what was going on. It's
Okay.
probably one of the weirdest responses you've gotten to that
No,
question
just
ever.
so you know that Dr. Krieger she's dipped in the oil that is science because all of her answers had some sprinkle of science in the mix. She's like, yeah, I'm curious about dynamics. I would like to go back and see what that experience was. Whereas like the Black woman in me is like, absolutely not. They're gone for a reason. Do not want to know who they are. Not interested. We asked I have another show. We asked a question, and the question was, if aliens from outer space, parked in front of your door and they were coming out, they were beaming out of their spaceship, what would you say? Every Black guest was like, I would just be like, I'm so sorry, not trying to find trouble, and I would exit stage left. And all of our other guests were like, I would say, hello, how are you doing? How's life in space? And we're like, yeah, that's not us.
Close the door. Close the door.
Yeah, that's really interesting. You do a whole show on that dynamic.
I would watch it.
Anyways, this conversation has been everything. It's been raw, it's been real, it's been necessary. Thank you, Dr. Krieger, for giving us an opportunity to ask questions that we know will better assist and guide our patients and caregivers in the community. But more importantly, you dropped so many nuggets of wisdom that anyone can appreciate and walk away learning a thing or two about the transformative process that they didn't know before. And for that, we're grateful. I love that in the hour we've sat with you, you've given us a history lesson and you've helped us to unpack things that now make better sense to those of us in this space. And so I hope our listeners take away, something from our little show, and to see that like every patient journey is unique, but each one is important for the field and the work that is being done with this space. Christelle, any final thoughts?
Yeah, that you've summed it all up, and I just thank you, Dr. Krieger, for partnering with us the same way you partner with your patients and the families that walk through your door. That persistence and depth of relationship that you have with your patients is so evident, and it spills over into how you show up with excellence here, and just really creating a space for us to feel, for warriors to feel like we're empowered, but that warriors and providers, that we're family. I feel that through this podcast with you. So I'm so grateful that you joined us. We know you're a busy doctor, a busy woman. So thank you so much for being here. And I know our audience members loved it. If this is your first episode with us, be sure to catch the rest of this season on anywhere you find your audiovisual content, whether it's Spotify, Apple Music, YouTube, Audible, you name it. We are there, and you definitely don't want to miss out on the next episode because we've got some good stuff cooking.
Thank you guys so much.
This show is brought to you by Beam Therapeutics, Synthago, and Kamal Therapeutics, with support from the UCSF Sickle Cell Center of Excellence, Through the Pain Inc., and Sickle Cell Prodigy.